Good morning, everybody. Actually, the previous speaker made my role very easy, but I'm going to present on the late presented Physeal injury. The basic aim is to when to intervene, when to leave. We'll have the option. We have seen the last presentation, but that's if we have the audience response on that. How do you manage this type of injury? As I think Sandeep has shown that it's presented after 10 days. Would you do it above elbow cast, close reduction pinning, or open reduction and internal fixation? Will you start? Yes. So it's almost 50-50. 50% wants conservative, 50% want the operative. Okay. We'll have the second example. As Sandeep has shown the example of the distal Physeal injury of the tibia. How do you manage a 23 weeks old injury? Okay, so that means having with almost well distributed along the audience there. So what I am going to talk on today is why these injuries are presented late, what is the natural history of this injury, when to leave and when to intervene. That's my main focus on today. Why this injury is presented late, and it's not uncommon scenario in India when this injury is very well missed even by some of the orthopedic surgeons. Why? Because sometimes it may present in very unusual site, which is not common, and sometimes we do have the casual approach, and we have seen that clinical accuracy has gone. Why is like that? I'll give an example. One child presented in trauma center with having the fall on outstretched hand. And initially the resident has taken the x-ray, not seen the patient and say, it's normal, just go, nothing has happened. This child belonged to one of the sister's childs, came after a week and say, this is x-ray. Why this injury has been missed? Because it's not done a proper clinical examination on that. Sometimes it's missed because of the inadequate investigation, like initially x-rays was normal and say it's missed. Why? Because the internal rotation X-ray is not been taken, and when you suspect about the elbow injury, you need to take about the X-ray in internal rotation and see whether the lateral condyle fracture is there, even though it's undisplaced, but it can lead to the disaster. Sometimes not knowing the pitfall, like the distal Physeal separation of the humerus. It's very common, and we'll see about the posteromedial displacement, and people will say it's elbow dislocation. It's not elbow dislocation, it's a transphyseal separation. And many times it's an undisplaced fracture, so nothing is going to happen for that, but it can lead to the disaster. What are the implications? It can lead to the angular deformity, it can lead to the limb-line discrepancy, it can lead to the distortion of the epiphyses and the joint incongruity, or it can lead to the stiffness like lateral condyle fracture. So we need to learn that what is the natural history. It's not always it's happening with the limb-line discrepancy, angular deformity, or the stiffness of the joint, or the epiphysis or joint problem. Sometimes it may be benign, and sometimes it will be having lifestyle disability like that. It's a lateral condyle undisplaced, gets displaced, and get to the severe valgus with the tardial nerve palsy. And it can lead to the lifetime disability. How can we manage these cases? We need to know the natural history of the Salter-Harris type 1 and Salter-Harris type 4. It's totally different. We need to know about what we want to achieve, how can we achieve, what are the options, and which is the best option, because they all do not behave the same. We need to consider the age of child, duration of injury, the type of injury, whether it's intra-articular or extra-articular. It is very important, even though it's presented late, and associated complication. There are the treatment options. You can do just observation or non-surgical treatment, open reduction, and prevent and treat the complication. Like same child is presented after the 7 days, and that's presented after 10 days, it's displaced. Just do the observation, do the above elbow cast if it is painful. If it is not painful, just leave it. Then it gets corrected by own observation. It's after 1 year of follow-up, it's remodeled quite well. The message in the Salter-Harris type 1 and type 2, best to leave it after the 1 week. You need not to do any attempt about the close reduction by the open reduction, because whatever you do, you are going to do more damage than doing good. If it is intra-articular injury like that, it's a lateral condyle fracture presented late, you can do about the prevention of the complication either by doing about the osteosynthesis and doing open reduction, and that get the good union. That would be the normal principle for the all Salter-Harris type 3 and 4 injury. If it is presented late, it can present with a residual bar like that. Its patient was treated by some of the surgeon and put about transphyseal screw, and transphyseal to the proximal tibia is a disaster. It can lead to the gross genu recurvatum, and we see about the gross physeal bar on the proximal of tibia, and it's been excised, and we have to deal with the residual recurvatum, and it's lead to the gradual correction of the deformity. It's got gradually corrected. This is 1 year follow-up, but we have to deal with the proximal tibial fusion, then we have to deal with the limb line discrepancies. Still it will be there, few amounts of limb line discrepancy despite of the physeal bar excision, deformity correction and limb lengthening. Has to go for either contralateral episiodesis or limb lengthening. One due surgery is required. This is the before and this is the after. It's reasonably good aligned. And limb line discrepancy at present is corrected, but the child is too young, it's around 12 years, so it required one more lengthening or the episiodesis on opposite side. What do we do for the late presentation, very late presentation? So late presentation, it's physeal injury miss and presented at the near skeletal maturity or just after the skeletal maturity, like that. It's almost physeal squared, fused with complex deformity with valgus and the procurvatum deformity. Then you can correct with by the basic principle, do only the correction of the deformity and the lengthening, if whatever it is required, the limb line discrepancy in that. In conclude, prevention is better than cure. You can treat it in acute stage rather than keeping for the late presentation. Always suspect the physeal injury in non-ossified and unusual places when you are doing acute. Type 1 and 2 should be left alone after the 5 to 7 days. An intra-articular injury require the normal anatomical resection. As like the adult, we do not accept about intra-articular strap. And the special attention, as Sandeep has mentioned, should be paid to prevent iatrogenic complications. Thank you.